Hello everyone, this is Dr. Garima Sachdeva and today we'll be discussing about endometrial cancer. We'll be discussing the latest Figo staging of endometrial cancer which has been released and also stage-wise management. So stay tuned, hope you find it useful.
Non-aggressive is low-grade endometrial cancer, that is grade 1 and grade 2. Aggressive is all other, either high-grade endometrioid cancer, grade 3, serous, clear cell, undifferentiated. So all others are aggressive. Okay. Hello.
I'm audible.
Yeah.
Yeah, I'm responding.
Yeah. Okay. So this is a staging. Stage 1 is divided into 1A, 1B, 1C, and 1A is further divided into 1A1, 1A2, 1A3. So stage 1 where it is limited to uterus and ovary. 1A1, 1A1C, 1A1 is non-aggressive, 1A2 is also non-aggressive, 1B is also non-aggressive, 1C includes aggressive. So aggressive,
Okay.
which is confined to endometrium, is 1C directly, and non-aggressive confined to endometrium is 1A1. So this much difference is there. Okay, so this was not there in the previous staging. Okay,
So this
previously
is the
they
new
had
stage.
not.
So this stage only has to be followed.
Yes, because this is the most.
And what it is limited to either to endometrium or limited to a polyp.
Or it is a small polyp. That's an endometrial polyp that is confined to the endometrium only.
Okay.
1A2 is less than half of the myometrium. So non-aggressive type. And if it is less than half of the myometrium, which is aggressive with any myometrial involvement, it directly goes to 2C. Okay.
Okay.
So this is difference is there. 1A3 is limited to uterus and ovary. 1B is non-aggressive with invasion of more than half of the myometrium with no or focal LVSI.
What is the difference between 1A2 and 1A2 and 1B?
It is less than half of the myometrium.
Okay.
Myometrium is
Here
more
it
than
is
half.
invasion of more than half. Okay.
Okay. 1C is aggressive, limited to endometrium.
Okay.
2 is where the cervix gets involved. So here cervical stroma we count. Glandular involvement is not counted, is not considered in the staging.
Okay.
So if it invades cervical stoma, it is 2A, and if there is substantial LVSI, lymphovascular space invasion, then that is 2B. I'll be telling what is focal LVSI, what is substantial LVSI in subsequent slides. Then 2C is aggressive with any myometrial involvement. Okay.
Completely.
Yeah.
Entire myometrium.
No, if it is aggressive, even if it is less than half of the myometrium, it is 2C.
How to make out it's aggressive?
I told you, no, aggressive or non-aggressive. Only non-aggressive is low-grade endometrial cancer. Other things are all aggressive.
Okay.
Then 3A, this you'll have to learn the staging because they give you the stage, they'll give you a scenario where first you have to identify the stage and accordingly then write the management. So that's how the questions come. So you'll have to learn these stages. 3A is if it invade uterine serosa, adnexa or both.
Okay.
3A1 is if it is only ovary and fallopian tube. 3A2 is uterine subserosa or it spreads through the uterine serosa. Okay.
Okay.
Then 3B is where it involves
Oh,
3B1
this
and
one
3B2.
is only uterine serosa and next are both. This is ovary and this is uterine subserosa. Oh, okay. Okay.
Okay. 3B1 is all this you will come to know only when you have taken out the uterus and for biopsy for evaluation what all is involved, right?
Yeah.
So that's why it is a surgical staging. 3B1 is vagina and parametrial involvement. 3B2 is involvement of pelvic peritoneum. 3C if the nodes are involved, which is also classified as 3C1 where pelvic lymph node is involved, REC2 where para-aortic lymph node is involved.
Okay.
And it is again divided into micro and macro metastasis. What is the difference? This also I'll be telling in future slides. 4A, if it involves bowel, bladder, matlab regional metastasis, adjacent organs to the uterus are involved. 4B is abdominal peritoneal metastasis beyond the pelvis.
Okay.
Then 4C is distant metastasis where renal vessels, lungs, liver, brain, bone are involved.
Okay.
Okay. Now, how do you manage? First, and again, now they have also included molecular profiling for prognosis. So you can, apart from this histopathology, you can also send the samples for immunohistochemistry. And if you find that there is mutation which is present for pole mutation, pole gene mutation is there, then it is good prognosis. If there is mismatch repair deficiency or microsatellite instability or no specific molecular profile, then it is intermediate prognosis, and P53 mutation, then it is poor prognosis. So this
Okay.
is also something which is newly added in the new guideline. It was not there previously.
Okay.
Then grading. I told you grade 1, grade 2, grade 3. So how do you establish the grading? It depends on histopathology how much is a solid component.
Mm.
Ideally, endometrium should have only endometrial glands, right? But
Yeah.
if you're having solid component, solid growth, then it is considered poor prognosis. Grade 1, if it is less than 5% solid non-glandular growth. Grade 2 is 6 to 50 up to 50%. Uh, Grade 3 is more than 50% of
Okay.
solid.
Mm.
And this is based on the architectural features. Now, grading also changes with the nuclear atypia. So, nuclear atypia, what will you see? Hyperchromasia, mitotic figures, all that. So, if you feel that nuclear atypia is excessive for the grade, then you raise the grade by 1. So, then if it is grade 1, it becomes grade 2 if nuclear atypia is more. And if it is grade 2, it becomes grade 3.
Nuclear atypia excessive for the grade. Mm. What it is, ma'am?
Nuclear atypia in terms of you see how much many mitotic figures are there, those
Okay.
cancer markers, how much hyperchromasia is there. So if you feel that it is very much, then and however solid component is less, but then again because of the nuclear atypia grade raises by
Okay.
1.
If it is more, that grade is raised.
Yes.
Okay. And this grading is made out from biopsy,
Yes.
endometrial biopsy.
Yes. Then about lymphovascular space invasion, it depends on the number of vessels involved, whether there is no lymphovascular space invasion, focal or substantial or extensive. If no means no vessel is involved. If less than 5 vessels are involved, then focal. If more than equal to 5 are involved, then substantial. Okay.
What is substantial? Extensive. Mm.
Okay.
Okay. Mm.
Then lymph node status, again, what is micrometastasis, what is macrometastasis, what are isolated tumor cells. So micrometastasis is zero point 0.2 to 2 millimeter size or up to 200 cells involved.
Okay.
Macro is larger than 2 millimeter size. An isolated tumor if up to 0.2 mm and up to 200 cells involved. And isolated tumor cells do not upstage the cancer. Micro metastasis and macro does.
Okay. Mm-mm.
Now management depends upon the stage. So if it is stage 1A, grade 1, okay, then
Okay.
you do staging. So you will do grade 1 laparoscopy. Staging mein what all you do, you remove the uterus, you remove the cervix, you do remove fallopian tubes and bilateral ovaries. But
Okay.
in grade 1 you need not do lymphadenectomy and you need not give any adjuvant treatment
Okay.
like
Mm.
chemotherapy or radiotherapy is not required. Stage 1A, grade 2, again you just do this here you can remove by laparoscopy also. 1A
Okay.
grade
Okay.
1.
Mm.
1A grade 2 you would have to do laparotomy only.
Why?
because it is spread more, no?
Okay.
So you do not want more spillage of the cells, so that's why you do laparotomy. But you
Okay.
do the same surgery. You remove the uterus, you remove tubes and ovary. No lymph nodes need to be removed. No adjuvant treatment is required. Okay.
Okay. What
One
is
A,
VBT?
vaginal brachytherapy.
Okay.
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 So 1A grade 3 or 1B grade 1 grade 2, you do surgery, you have to remove the lymph node and you also have to give local radiation. That is
Okay.
through vagina you give radiotherapy. That is
Okay.
called vaginal brachytherapy. If it is 1B grade 3, you do everything, you remove the uterus, you remove the lymph node, you give radiation through vagina, vaginal brachytherapy. You also give to the pelvic nodes, you give external beam radiotherapy, EBRT. From pelvis also you give from radiation.
Okay.
Okay, stage 2 again same. You it is same like 1B grade 3. Okay, stage 3, stage 3, it is same with or without chemotherapy.
Okay.
And stage 4 you only do because it is extensive spread, so you can only do, you individualize. You just have to do palliative treatment. Anyways, the prognosis is poor.
Okay.
Okay, so you decide whether you have to give surgery, radiotherapy. It is decided by the onco multidisciplinary team. Okay, staging laparotomy for extrafacial total hysterectomy with bilateral salpingo-oophorectomy with retroperitoneal lymph node dissection in stage 1A, grade A. You do not require complete surgical staging. So you can do laparoscopy alone. Okay, you need not do laparotomy in stage 1A, grade 1.
Okay.
That I've already told. And all the enlarged and suspicious lymph nodes should be removed. If grade is high, or if there is grade is 3, or if there is deep myometrial invasion, or if serous or clear cell histology or cervical extension, then you, in all these stages, this also I've already told, you will have to remove the lymph nodes also.
Okay.
And what lymph nodes you remove? You remove complete pelvic lymph nodes,
Okay.
paratraumatic only if they are enlarged.
Okay.
Or you just do the sampling in cases if you feel that there is suspicious or grossly positive adnexa, grossly positive pelvic nodes, high grade tumors with full thickness myometrial involvement, or if it is aggressive types like clear cell, papillary, carcinosarcoma, etc.
Okay.
Then this is again the summary how to remember. Low risk, uh, which includes stage 1A, grade 1, grade 2. You do not require any additional treatment.
Okay.
Okay. Intermediate risk is 1A, grade 3, 1B, grade 1 and 2, where you have to give vaginal vault brachytherapy. Okay.
Okay.
And high risk, which is stage 1B, grade 3, serous clear cell aggressive types, where you have to give external beam radiotherapy also. This is about the radiation. Okay, if LVSI or lymph node positive, again it is extensive, so you give external beam radiotherapy also in those cases. And all other stages, even in advanced stages, so beyond this stage 1B grade 3, you give vaginal brachytherapy, external beam radiotherapy to all. However, if lymph node is negative, you can only give vaginal brachytherapy in selective cases.
If lymph node is negative, how about lymph node dissection?
No, no, lymph node dissection. Radiotherapy you give after surgery.
Okay. Oh,
Right?
like it. Okay.
Just after surgery. Okay.
Okay.
So
Then what is that
lymph,
lymph node negative?
you have taken out the lymph node. It
Okay.
was advanced stage. You had sent for histology. Now
Okay.
they can be positive for cancer or they can be negative for cancer.
Okay. Anyhow, we are dissecting it.
Yes, you have to
Okay.
do it. You have to do it for all beyond this stage. Beyond this 1A grade 3,
Great.
and for everybody you are removing the lymph nodes.
Okay.
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 Only for 1A, grade 1, grade 2 you are not doing it. For
Okay.
other everybody you are doing it. And
Okay.
beyond 1B grade 3 you are also giving external beam radiotherapy along with vaginal brachytherapy.
Okay.
So that's why it is important to remember the stage, because they'll give you a scenario where first you have to identify what stage is it, and then based on that decide what treatment you will give. So only these very direct questions come from oncology module. So they
Okay.
are mostly memory based.
Okay.
Okay. Then stage 1A, grade 1, do not require this, I've already told. No surgical staging is required, so you can just do laparoscopy. Stage 1A, grade 1, grade 2, you do not remove the lymph nodes. And stage 1A, grade 1 and grade 2, no adjuvant treatment like no radiotherapy, brachytherapy and all have to be given. Then stage 3 and 4, the basic aim is palliative therapy. So you do surgery, full staging, you do lymph node dissection, you also give post-op radiotherapy.
Okay.
Both external beam radiotherapy as well as vaginal brachytherapy. And patients with clinical stage 3 endometrial cancer in which surgical resection is not possible, if you feel that surgery is not possible, then you just give them pelvic radio chemotherapy. Okay. If the disease seems resectable after completion of therapy, then you can do exploratory. Okay.
Okay.
If you feel that you will not, it is so much extensive that you will not be able to remove it. So first, in order to suppress the disease, you give radio chemo, and after that you do laparotomy if possible.
Okay.
Then stage 4, I told you have to do individualized treatment because it is just palliative therapy. Prognosis is not very good. So most common metastasis in stage 4 is mostly pulmonary metastasis, which is the most common site. And this question is asked, progesterones have found to be useful in pulmonary metastasis. So progesterone treatment is given for pulmonary metastasis. Okay.
Okay.
So you give in this stage 4, you give surgery, radiotherapy, chemotherapy, and the patients who are not suitable for surgery, you give them chemotherapy, neoadjuvant chemotherapy. And what chemotherapy you give? You usually give carboplatin and paclitaxel. So for endometrial, ovarian, every day you give carboplatin and paclitaxel. Okay. Progesterones for pulmonary metastasis. Pelvic radiotherapy in stage 4 is sometimes considered to provide local tumor control. Similarly, it is also often suggested that patients with vaginal bleeding or pain from local tumor mass or with leg edema due to lymph node involvement should be treated with pelvic radiotherapy. Palliation of brain and bone metastasis can be effectively obtained by short courses of radiotherapy. So for brain bone metastasis also you give radiotherapy to
What is
those.
that NCT?
Or neoadjuvant chemotherapy.
Adjuvant chemotherapy. And so in laparotomy surgery, they may
Huh?
do hysterectomy post radiotherapy.
Yes.
And how progesterone is working in pulmonary metastasis?
I've seen that it helps. Because progesterone helps no anyways in endometrial. If there is heavy bleeding, you give LNG, IUS.
Yeah, but
So
there
they
is
suppress the
metastasis.
endometrium. So that's why it has been seen that in pulmonary metastasis it has been helpful. There have been studies.
Okay.
Okay. Now suppose you have done hysterectomy for some other reason, like for fibroid or something, heavy bleeding, PID, anything. You've done hysterectomy and you found cancers, endometrial cancer. So in grade 1 and grade 2, with no lymphovascular invasion, you need not do any further treatment. You just follow up those patients. Okay.
Okay.
However, in all other stages, you treat according to the stage. You have to do the complete staging, full staging laparotomy again. Okay, and then further management
Okay.
based on the stage you get. Okay.
So this was all about the latest Figo staging of endometrial cancer. Hope it was useful. Thank you so much for watching.